Surprise!
Okay. That means extra work. In the update in treatment of lung cancer. We're going to go ahead and get this session started now. It is my pleasure to welcome you to the update in treatment of lung cancer. A few housekeeping items first. You can find complete speaker bios located on the HOPA website under the Conference Web Central. We ask that you hold all of your questions until the end. And to participate in the polling questions for this session, please open a web page browser and enter ra.ombea, that's O, M as in methotrexate, B as in bortezomib, ea.com. The session ID is HOPA1. You can also access the polling through the HOPA app. Polling will not activate until the speaker has reached a polling slide. It is my pleasure to introduce to you your faculty for this presentation. Eve Siegel is a clinical oncology pharmacist at the Seattle Cancer Center Alliance and the University of Washington Medical Center. Welcome, Eve.
Thank you. All right, thank you for the introduction. Today we'll be discussing novel therapies in lung cancer. I have nothing to disclose. Our presentation today will cover three main objectives. First, we will describe the role of various signaling pathways involved in the development and the progression of lung cancer. Next, we will review novel therapeutic options for the treatment of non-small cell lung cancer. And then lastly, we will discuss available data for the use of targeted therapies and immunotherapy in the management of advanced or metastatic non-small cell lung cancer. I wanted to provide you with a little bit of background. In the US, lung cancer occurs in about 225,000 patients and is responsible for 160,000 deaths annually. Now, the frequency of lung cancer has risen, The frequency of lung cancer has risen dramatically. So around 1953, lung cancer became the most common cause of cancer deaths in men. And then in 1985, it became the leading cause of cancer deaths in women. Now, lung cancer deaths have begun to decline in both men and women, and this reflects a decrease in smoking. But 1 in 4 deaths due to cancer today are expected to be from lung cancer. All right, it's skipping slides. Bear with me one moment. Okay, so approximately 95% of lung cancers are classified into 2 buckets, either small cell lung cancer or non-small cell lung cancer. Now, this distinction is crucial for our staging, our treatment, and prognosis. Small cell lung cancer is the most aggressive clinical course of lung tumors. It has the clearest relationship to smoking and it's highly sensitive to both radiation and chemotherapy. Non-small cell lung cancer accounts for 80% of all lung tumors, and most patients present with metastatic disease at diagnosis. There are 3 major histological subtypes of non-small cell lung cancer. We have adenocarcinoma, squamous cell carcinoma, and large cell or undifferentiated carcinoma. Adenocarcinoma is the most common histological subtype in both men and women combined, and it's the focus of our presentation today. Okay, I really love this slide. So 10 years ago, the idea that all genes altered in cancer could be identified at the base pair resolution would have seemed like science fiction. But today, such genome-wide analysis is routine. We have learned that in common solid tumors, like those derived from the colon, the breast, or the pancreas, an average of 33 to 66 genes display some subtle somatic mutations that are expected to alter their protein products. Most of these mutations are single-base substitutions. The remainders are deletions or insertions of one or a few bases. Now, certain tumor types display many, many more or many fewer mutations than average. And notable among the outliers are melanomas and lung tumors. They have about 200 mutations per tumor. And these larger numbers reflect the involvement of potent mutagens like ultraviolet light and cigarette smoking. And notably, lung cancers from smokers have 10 times as many somatic mutations as those from non-smokers. Okay, to piggyback off the last slide, about 60% of adenocarcinomas harbor somatic driver mutations. Oncogene activation can occur by gene amplification, overexpression, point mutation, or DNA rearrangements. And this results in an upregulation of signals that induces cell growth. Importantly, it can result in this oncogene addiction, where the cell becomes dependent on these aberrant oncogene signals for survival. Now, there's also loss of tumor suppressor gene function, and that's a crucial step in lung carcinogenesis. It usually results from chromosomal inactivations, deletions, or translocations. And commonly inactivated tumor suppressor genes are P53, RB1, and PTEN. Now, tumor suppressors have been this really challenging target for therapeutic agents because restoration of lost activity is much more challenging than inhibition of increased activity. Okay, in non-small cell lung cancer, 2-drug platinum-based chemotherapy improves survival and quality of life in patients with good performance statuses. The nuts and bolts of chemotherapy in lung cancer as follows. So chemotherapy with 1 or 2 drugs is better than best supportive care. 2-drug regimens are more effective than 1-drug regimens, but 3-drug regimens are not more effective than 2-drug regimens. Platinum-based doublets are effective in elderly patients with good performance statuses, but the benefit of chemotherapy in patients with performance statuses greater than 2 remains uncertain. Essentially, when you read all of these trials, chemotherapy confers an overall response rate anywhere from 20 to 50%, and a median survival of anywhere from 6 to 10 months. Now, if you have a patient with a performance status of 0 to 1, you could add bevacizumab to your doublet chemotherapy, but you must make sure your patient doesn't have a squamous cell histology or a recent history of hemoptysis. If you have a patient with a performance status greater than 2, you could use doublet chemotherapy with carboplatin and pemetrexed or single-agent therapy. Okay, platinum doublets are the backbone of non-small cell lung cancer treatment, but targeted therapies have established our role among our mainstay agents. This begs the bigger question, what is targeted therapy? If you were a patient of mine, I might say targeted therapy is very sophisticated. It's like a smart bomb versus chemotherapy that's like a nuclear bomb. I don't think many patients find that comforting. And it's technically not correct, right? Targeted therapy potentially applies to all cancer treatments. Conventional cytotoxic chemotherapy is targeted against DNA replication. But when we say targeted therapy, we are usually referring to 2 classes of drugs, either small molecule TKIs or monoclonal antibodies. The holy grail of cancer therapy would be one where we achieve a favorable efficacy to toxicity profile. We want a therapy that kills the tumor, but not the normal cells. We want a molecular target that's expressed on or within the cancer cells themselves. But as we see from our available targeted therapies and the adverse effect profiles that they have, these pathways are not so distinct. Great, we'll kick off our presentation with EGFR inhibitors. The epidermal growth factor receptor belongs to a family of receptor tyrosine kinases that trigger a vast array of signaling pathways leading to cell growth and proliferation. Overall, there's a lot of redundant pathways and flow-on pathways like the MAPK and the mTOR pathways. However, there are three main mechanisms leading to EGFR activation. First, you can have increased expression of EGFR, or you can have enhanced ligand production, or you can have activating mutations of EGFR within the malignant cells. EGFR itself is overexpressed in up to 80% of non-small cell lung cancers, and it was this really promising translational therapeutic target. Early trials of EGFR or HER1 TKIs were in these really unselected populations, and as the trials matured, subgroup analysis identified characteristics that correlated with the response, like adenocarcinoma histology, Asian ethnicity, or minimal smoking history. And then molecular testing of tissue samples from responders revealed that activating mutations in EGFR underpinned our responses seen. So we discovered that activating mutations, rather than pure overexpression of EGFR, was our true therapeutic target. Now, unfortunately, there's no reliable clinical characteristics that's going to help you predict what patient has an EGFR mutation and what doesn't. So all tumors should be tested for EGFR mutations. Sorry, it's different than a Mac. Okay. The most common mutations are exon 19 deletions and L858R missense substitutions. Both are drug sensitizing, and together represent about 85 to 90% of EGFR mutations in lung cancer. You also have some other exon mutations for EGFR. So exon 18 is a drug sensitizing point mutation, as is exon 21. But it's important to know that exon 20 insertions might predict resistance to EGFR TKI therapy. Gefitinib and erlotinib were the first EGFR TKIs to be developed. Both are reversible competitive inhibitors of ATP for the tyrosine kinase domain of EGFR, and that results in this blockade of downstream pathways. Now, whereas erlotinib and gefitinib are a relatively pure EGFR inhibitor, afatinib is a multi-kinase TKI. It's irreversible for EGFR, HER2, HER4, and has activity in T790 clones. The implication is that afatinib might work better in the long run, and it might provide therapeutic salvage for patients whose tumors have progressed beyond the first generation TKIs. Osimertinib also irreversibly inhibits mutant forms of EGFR, as well as HER2, HER3, and HER4. The adverse effect profile with gefitinib, erlotinib, and afatinib is consistent with inhibition of wild-type EGFR. So which is predominantly expressed on epithelial cells, and therefore diarrhea and acneiform rashes are the most common adverse effects we see. Osimertinib has more potency for mutant EGFR compared to wild type, so you see less adverse effects. But it's important to know osimertinib inhibits HER2, so patients should have their ejection fraction monitored every 3 months while they're on therapy. The data surrounding erlotinib, gefitinib, or afatinib suggests that these targeted therapies should be used in the first-line setting. Now, know that this chart is not a comprehensive list. There's about 13 phase 3 trials where an EGFR TKI was compared with platinum-based chemotherapy. However, in all the trials, the response rates with EGFR TKI was nearly double, and the progression-free survival times were significantly longer as well. It's interesting to note that none of these trials demonstrated an improvement in overall survival. And that could be attributed to the fact that most of these trials were not set up to confer an overall survival benefit, and most patients crossed over from chemotherapy to an EGFR TKI. But in all of these trials, quality of life parameters were significantly longer and superior with the TKI. Let's take a step back. We have 3 available oral TKIs. How do we select what agent should be our first choice? There are very few head-to-head comparison studies. There was a phase 3 WJOG 510 trial that compared gefitinib and erlotinib. Erlotinib demonstrated a better efficacy with a progression-free survival of 10 months compared to 8.3 months with gefitinib. But there were a few flaws. The study was in patients who progressed on chemotherapy. Only 72% of the patients in this trial were positive for EGFR mutations. But serious grade toxicities were worse with erlotinib, about 18%, compared to 2% with gefitinib. We also have the LUX-Lung-7 trial, which is here on this slide. Patients were randomized to receive either gefitinib or afatinib. Overall, disease outcomes were modestly improved with afatinib. Time to treatment failure was longer for afatinib, but more patients, about 11%, experienced serious treatment-related adverse effects compared to 4% receiving gefitinib. Therefore, the choice of our oral TKI needs to be individualized according to patient and provider preferences. Available data suggests that all three agents have roughly the similar effectiveness, and the NCCN guidelines recommends each agent as a category 1, and they are generally well tolerated. The perception is that the toxicity profile is somewhat worse for afatinib than for erlotinib or gefitinib. Stomatitis has only been reported with afatinib, not the other two drugs. And clinical trial data has shown higher rates of diarrhea with afatinib compared to erlotinib. So to aid in the selection of EGFR inhibitors, pharmacists can play a vital role. In general, patient age, body weight, gender, or ethnicity do not have a clinically relevant effect on the clearance or exposure of gefitinib, erlotinib, or afatinib. Mild and moderate hepatic and renal impairment do not appear to have a major impact on the exposure of the EGFR TKIs, so preemptive dose adjustments is not routine. With the exception of afatinib, you should dose reduce it if your patient has severe renal impairment. Potential drug interactions to be considered for individual agents include interactions with drug transporters, CYP enzymes, and acid-reducing drugs. Concomitant use of H2 receptor antagonists and PPIs can substantially reduce the plasma levels of gefitinib and erlotinib. But there were these two small retrospective studies, one of 100 patients and one of 190 patients, that showed if you do give acid-suppressing drugs with gefitinib and erlotinib, it won't have a significant impact on their disease outcomes or toxicity profiles. I personally think a lot of prospective trials are needed to validate this point, but a provider and I often have a healthy debate whether or not this study has a clinically relevant impact. Also know that cigarette smoking induces CYP1A2, and it could reduce the plasma exposure of erlotinib. So you need to double the dose of erlotinib in patients who are active smokers to 300 milligrams, and you should titrate them up in 50 milligram increments. One second. Okay. So in 2017, the NCCN totally rocked my world. Historically, if I was going to show this slide, I would say if you have an EGFR mutation and you discover your EGFR mutation during first-line chemotherapy, you should immediately switch to an EGFR TKI. But in 2017, they changed their recommendations. So if you do discover an EGFR mutation during first-line chemotherapy, you could complete planned chemotherapy, including maintenance chemotherapy, or switch to the TKI. Now know that this recommendation is not based from evidence, it's expert opinion. So most providers would switch to an EGFR agent, but you could conceivably continue chemotherapy. Okay, this slide doesn't really fit anywhere, but it's an important update. Cetuximab is a monoclonal antibody that targets EGFR. Its inclusion in the NCCN guidelines was based off the large phase 3 randomized trial known as the FLEX trial. The trial randomized over 1,000 patients with advanced non-small cell lung cancer, and it found that adding cetuximab helped to slightly increase overall survival by approximately 4 weeks. However, the cetuximab cisplatin venetoclax regimen was recently removed from the NCCN guidelines. The committee stated that the benefit of this regimen was modest, it's a very challenging regimen to administer, and it's poorly tolerated. So about 40% of the patients in the FLEX trial had grade 4 neutropenia. So although the results were reported to be statistically significant, they're not clinically significant. All right, we have arrived at our first audience response question. JG is a 57-year-old male, never smoker, presents with a complaint of a persistent cough and a 20-pound weight loss. He underwent extensive testing, was found to have metastatic lung adenocarcinoma with a deletion 19 mutation. He was started on erlotinib and has been on therapy for the past 10 months. He had a recent CT scan that demonstrated increased pulmonary nodules with new liver lesions, and he reports feeling symptomatically stable. A biopsy was performed, and his cancer is now T790M mutation positive. So what is the most appropriate course of action for this patient at this time? Is it A, start treatment with carboplatin and pemetrexed, B, start treatment with osimertinib, C, continue erlotinib therapy, or D, order a repeat biopsy? Give you a few more minutes. Okay, it looks like we're slowing down. Okay, great. So most patients become resistant to initial therapy about 8 to 16 months. The T790 mutation is associated with acquired resistance to TKI therapy, and it's been reported in about 60% of patients with disease progression on EGFR inhibitors. Now, once the T790M mutation emerges, the median survival of these patients is less than 2 years. Know that the T790M mutation can occur in patients who have never been exposed to an EGFR TKI, but this is a pretty rare event. I have not seen it yet. Additionally, it's important to know that acquired resistance might be associated with a histological transformation from small cell lung cancer, from non-small cell lung cancer to small cell lung cancer. So it's important that tumors are retested for their pathology. Once you progress on your first-line EGFR therapy, the NCCN recommends 4 different options, either local therapies, systemic chemotherapy or immunotherapy, continue your current EGFR therapy, or treatment with osimertinib. This slide here is for completeness. One modality of treatment in acquired resistance is the use of local therapies like radiotherapy, local ablation, and surgery if your sites of progression are limited. This recommendation is based off of 2 retrospective trials that demonstrated substantial median times to progression, but prospective trials are needed. Osimertinib is probably one of the more exciting agents to come to the market in 2015. I might be a little bit biased, though. Its approval was based off the phase 1 and 2 Aurora trial. This trial included dose escalation and dose expansion cohorts. A rolling dose escalation design was used, where after 7 days, patients received the same oral dose for the remainder of the trial. And the first dose tested was 20 milligrams, and each subsequent dose cohort represented a 100% increase from the previous dose, with the exception of the last dose escalations. Patients continued until the development of unacceptable toxicities or disease progression. A total of 239 patients could be evaluated for response. 51% had a confirmed partial response. 1 patient had a complete response, which is really exciting. 33% had stable disease, and 14% had progressive disease. The median progression-free survival was 8.2 months. And what they found was doses of 80 milligrams demonstrated a more profound inhibition of tumor growth and limited side effects. Now, there's been a few updates to the original Aurora trial. There's also been a phase 3 Aurora 3 trial that helped get its FDA approval. But the overall response rates are anywhere from 60 to 75%, and it looked like the progression-free survival is about 10 months. So therefore, any patient with a T790M mutation should be considered for treatment with osimertinib. Now, know that osimertinib is also being evaluated in the first-line setting. That theory is that their time to disease progression will be a lot longer. It's also being studied at doses of 160 milligrams because the hypothesis is that you'll have better CNS penetration. Another question that's been explored with these agents is, can we continue our EGFR therapy after our initial progression? And this phase 1b trial attempted to answer that question. Here, 126 heavily pretreated patients were treated with afatinib plus cetuximab. Of the 126 patients, 29% had a confirmed objective response, and 22 patients actually saw their tumors shrink by more than 50%. In addition, there was no significant difference in objective response rates between patients who harbored the T790M mutation and those who were negative. The overall median duration of response was 5.7 months. Now, what's interesting about this trial is a benefit was seen regardless of your T790 status. Additionally, this trial also demonstrates that EGFR mutant lung cancers that have acquired resistance are still dependent on EGFR signaling for their growth and survival. So the NCCN says you could use this, this regimen in patients who have progressed on frontline EGFR therapy, and it might be a good option for patients who are T790M negative. Let's put the picture together. If you progress on first-line EGFR therapy, the NCCN recommends the following. If you are asymptomatic, symptomatic with brain involvement only, or symptomatic with an isolated lesion, you could consider local therapy. You could switch to osimertinib if you're T790M positive, or continue your EGFR TKI. But that recommendation needs to be individualized, and additional therapy might need to be added for those patients. However, if you're symptomatic with multiple lesions, you would switch to osimertinib if you're mutation positive, or you could use systemic chemotherapy or systemic immunocheckpoint inhibitors if you're PD-L1 positive by more than 50%. All right, let's switch to ALK inhibitors, which are my favorite targeted therapies. So KL is a 30-year-old previously healthy woman who presented with decreased exercise tolerance. Her past medical history is significant for exercise-induced asthma. She does have a brief cigarette smoking history from age 17 and 22 years. A chest X-ray did show diffuse disease. She was treated with antibiotics, found to have no improvement. A chest CT was performed and showed diffuse lung nodules. A brain MRI was negative, and molecular testing was conducted, which was positive for ALK. So based on the above patient case, what would be the most appropriate therapy to start in this patient? A, alectinib, B, ceritinib, C, crizotinib, D, cisplatin and pemetrexed. Oh, I closed the polling too early, I'm sorry. C is correct, but 3 of you who said B, you are now also correct as of a week ago. And we'll go into that a little bit. ALK gene rearrangements are estimated to occur in about 3 to 7% of patients with non-small cell lung cancer. Patients with ALK mutations have very similar clinical characteristics as those with EGFR mutations, like adenocarcinoma histology, and they tend to be smokers or light smokers. But the exception is that these patients tend to be younger. Now, ALK itself is involved in the development of brain and neurons. It's highly expressed during embryogenesis, and then it becomes dormant. Most mutations of ALK are in the form of translocation with another gene, leading to a fusion oncogene that becomes overtly expressed in cancers. And these translocations result in increased tyrosine kinase activity, leading to increased cell proliferation and cell survival. The ALK pathway is very similar to the EGFR pathway. It involves JAK signal transduction, activation of PI3K and mTOR, as well as MAPK signaling cascades. There are a number of therapies for ALK-positive mutations, and lucky you, we're going to review them all. Crizotinib is the standard initial therapy for these patients. It's an inhibitor of ALK, ROS1, and some MET tyrosine kinases, and it yields very high response rates and overall is pretty well tolerated. The most significant adverse effects tend to be ocular toxicities. You could have edema, nausea, diarrhea, bradycardia, but this seems to be a class effect, and changes in renal function. The Profile 1014 trial randomized patients who were treatment naive to receive either crizotinib or standard IV therapy. And what the authors found was that there was a substantial benefit in overall response rate and progression-free survival with crizotinib. There was no difference in overall survival, though, and that could be due to the fact that there was a relatively low rate of death from any cause in the trial, and 70% of patients who were in the chemotherapy arm crossed over to receive crizotinib. Crizotinib did demonstrate a better side effect profile compared to chemotherapy. With crizotinib, we saw more visual disorders and diarrhea. Compared with chemotherapy, we saw higher rates of nausea and neutropenia. Permanent treatment discontinuations due to treatment-related adverse effects were 5% in the crizotinib arm compared to 8% in the chemotherapy arm. So as promised, a couple of days ago, the NCCN updated their recommendations for ALK-positive disease in frontline therapy. After a little bit of profanity and some emails to HOPA, we updated the slides so you have the most current recommendations. So if you have a patient with ALK-positive non-small cell lung cancer and you discover it prior to chemotherapy, you could use crizotinib or now ceritinib, and we'll discuss that trial later. If you have ALK-positive discovered during your first-line chemotherapy, you could again complete your planned chemotherapy or interrupt and treat with either crizotinib or ceritinib. Almost all patients develop resistance to crizotinib within the first 2 years of treatment. There are case reports of patients with brain metastases having a CNS response to crizotinib, but a major limitation of that drug appears to be poor activity in the CNS. So for example, there was this retrospective analysis of trials involving crizotinib, and 20% of the patients who did not have CNS disease at the beginning developed CNS metastases while on therapy. Several distinct mechanisms of resistance have been reported. In a third of resistant cases, tumors acquire a secondary point mutation. You could also have amplification of the ALK fusion gene, or a number of alternative or bypass signaling pathways like abnormalities with EGFR and KIT have been suggested, and that kind of alludes us to the potential need for combination therapies to overcome resistance. Second-generation ALK inhibitors were developed to overcome crizotinib-resistant mutations and improve activity in the CNS. There are 2 FDA-approved second-generation ALK inhibitors, ceritinib and alectinib. Ceritinib is a competitive TKI. It's 20 times more potent than crizotinib. In ALK-positive cell line models of acquired resistance to crizotinib, ceritinib inhibited resistant mutations like L1196M, G1269A, and I1171T, and they'll become important later. Alectinib is also highly selective. Like ceritinib, it's active against ALK point mutations and has activity in brain metastases. Treatment with both agents is, the adverse effect profile with both agents, they do differ. Treatment with both are pretty well tolerated. So with ceritinib, we're worried about GI side effects like diarrhea and nausea and vomiting. For alectinib, we're worried about hepatic and renal toxicities, taste changes, and photosensitivities. So it's recommended that all patients with alectinib wear SPF 50 while on treatment and for 7 days after treatment discontinuation. Ceritinib was approved in 2014. Its approval was based off the phase 1 ASCEND-1 trial and the phase 2 ASCEND-2 trial. ASCEND-2 was a single-arm open-label trial of 140 patients with ALK-positive disease who progressed on crizotinib. Objective response rate in that trial was 45%. Median duration of response was 9 months. In subgroup analyses, ceritinib had responses in patients with brain metastases. Now, alectinib is also highly active in patients who progressed on crizotinib. Single-arm studies demonstrated that alectinib can induce responses in close to 50%. It produces very durable responses, with median durations of response being 13 months. And median progression-free survival was also comparable at 8 months. Now, these 2 trials demonstrated alectinib's effectiveness in treating CNS metastases. Unlike other trials with ceritinib or crizotinib that assess these responses retrospectively, alectinib demonstrated it prospectively, and its indication is included in FDA labeling for patients with brain metastases. Pooled analysis of 136 patients with baseline CNS metastases demonstrated relative response rates of 45% and median duration of response for 10 months. Administration, side effect profile, and patient monitoring are different between our second-generation ALK inhibitors and represent a great area for pharmacist involvement. Hepatotoxicity, cardiac toxicity, and pulmonary toxicity is seen with both agents. Both are metabolized by CYP3A, but caution should be used when ceritinib is given concomitantly with CYP3A4 inhibitors. Some unique toxicities for alectinib is the risk of myalgia. Patients should have their CPK monitored during their first month of treatment. If there's any elevations in CPK with alectinib, your treatment should be held and then dose reduced. With ceritinib, we're worried about hyperglycemia and pancreatitis that's been reported, so patients should be monitored periodically. Well, we're at a crossroads in the second-line setting. What's better? Is it to get crizotinib first, followed by alectinib, or ceritinib? I think there's going to be a lot of subset analyses from the trials I listed on the slides before that dictate how we treat patients with ALK-positive lung disease going forward. There have been no randomized head-to-head trials, so it's really difficult to compare efficacy and safety of these agents. But it does appear that systemic efficacy of both drugs may be roughly comparable. So the choice of next-generation ALK inhibitor needs to be individualized for each patient. Now, related and perhaps more important question is whether patients can benefit from both drugs, right? One given after another. There is data supporting the sequential use after alectinib for alectinib after ceritinib, like in the setting of CNS metastases or ceritinib-resistant mutations like F1174V. Additionally, there's also data supporting to use ceritinib after alectinib, like in the resistant mutation I1171. It's important to note that most of these resistant mutations don't appear after crizotinib therapy, so serial molecular genotyping is required. Now, when we think about the next generation ALK inhibitors, sometimes the question is, how can we move them into the first-line setting? New to 2017, we have data from the ASCEND-4 trial, which evaluated 376 treatment-naive metastatic ALK-positive patients, randomized them to either ceritinib or platinum-based chemotherapy. The median progression-free survival was longer with ceritinib than for chemotherapy, and just recently, the NCCN added ceritinib as a Category 1 recommendation for the first-line setting. Overall survival data was not reached for ceritinib, compared to 26.2 months, which is substantially long, in the chemotherapy group. Now, in alectinib, we have both the J-ALEX and the ALEX trials that are attempting to evaluate this question. In the J-ALEX trial, Japanese patients were randomized to either alectinib dosed at 300 milligrams BID or crizotinib. Median progression-free survival for alectinib was not reached, compared to 10.2 months for crizotinib. Now, the international ALEX trial is ongoing. That's using alectinib dosed at 600 milligrams BID. And in October of 2016, the FDA fast-tracked alectinib in the first-line setting. So the NCCN recommends the following if you have ALK-positive disease progression. If you're asymptomatic or symptomatic in the brain only, you could continue local therapy, or you can continue with crizotinib or ceritinib, or you could switch to ceritinib or alectinib if you have not used ceritinib in the first-line setting. Now, if you're symptomatic and systemic with an isolated lesion, you should consider local therapy or continue crizotinib or ceritinib. But if you have multiple lesions, you would either switch to ceritinib if you have not seen it before, or alectinib, or systemic chemotherapy. Okay, we'll wrap up our talk with immunotherapy. Immunotherapy is not a new idea in the treatment of cancer. The concept to develop a treatment that uses the immune system to control and eradicate tumors. Older immunotherapies have had some success, albeit limited. Now, different strategies have been developed to elicit an immune response against tumor cells. Overall, 3 distinct approaches are available. Okay. First, there's a passive supply of antibodies targeting specific tumor-associated proteins. This sounds a lot like targeted therapy, right? But it's not fully understood how much activity with these targeted therapies could be related to antibody-dependent cytotoxicity. Second, we have the use of cancer vaccines that prime the immune system to produce antibodies against relevant tumor-associated antigens. And then lastly, we have non-antigen specific modulation of the immune system by using monoclonal antibodies that modulate T cell activity. Mounting evidence suggests that the predominant mechanism by which non-small cell lung cancer evades detection and elimination of the immune system is through the expression of PD-L1. I'm not going to review the mechanism of PD-L1 inhibitors. You've probably heard it about 15 times up to this point. But trials in lung cancer compared to other solid tumors have demonstrated that PD-L1 expression can correlate to increased response rates. However, there's also studies of PD-L1 expression in lung cancers that have said if you are PD-L1 negative, you might also respond to immunotherapy treatments. So is PD-L1 expression as a surrogate endpoint the best we have for predicting responses to immunotherapy? I think the whole concept of biomarkers linked to immunotherapy is a really confusing one. It's also one that we're just beginning to understand. There's a lot of shortcomings with PD-L1 expression. So first, there are 4 commercially available tests to evaluate a patient's PD-L1 expression. And it turns out they all have different terms for what's positive and what's negative. Next, PD-L1 can be expressed by both the tumor and the inflammatory cells within the microenvironment. The relative importance of either is unclear. And lastly, PD-L1 status is not this binary or fixed measurement. It's not like HER2 positive breast cancer. It can change during treatment course or throughout disease progression. This slide here is just for your reference. I'm not saying this because we're in California, but there's been a literal earthquake of PD-L1 inhibitors being approved for non-small cell lung cancer. It started in 2015 when nivolumab was FDA approved for metastatic squamous cell non-small cell lung cancer, and then pembrolizumab joined, and then they both kind of competed for rapid expansion of their indications and place in therapy. We'll start our journey with the FDA approvals. So in phase 2, phase 3 KEYNOTE-10 study, it randomized over 1,000 patients with previously treated non-small cell lung cancer who are at least 1% PD-L1 positive to pembrolizumab, dosed at 2 milligrams per kilogram or 10 milligrams per kilogram, or docetaxel. Now, compared with docetaxel, pembrolizumab was associated with improved median overall survival in the overall patient population. However, it was also associated with similar median progression-free survival in the overall patient population, which is pretty interesting, approximately 4 months in each group. Now, there was improved median overall survival and progression-free survival among our 442 patients that had at least 50% PD-L1 positivity. There were fewer grade adverse effects with pembrolizumab compared to docetaxel, but there was more pneumonitis being reported with the pembrolizumab group. Nivolumab got FDA approval for non-small cell lung cancer adenocarcinoma based off the phase 3 CheckMate 057 trial. That randomized 582 patients with non-squamous non-small cell lung cancer who experienced disease progression following chemotherapy to nivolumab dosed either at 3 milligrams per kilogram or docetaxel. In this trial, overall survival was prolonged with nivolumab compared to docetaxel. Objective response rates from nivolumab were greater as well, 19% compared to 12% with docetaxel. And median durations of response were 17 months for nivolumab compared to 6 months for docetaxel. Now, any degree of tumor PD-L1 expression was associated with improved survival with nivolumab, but patients who were PD-L1 negative had similar survival rates as those who received docetaxel. In late 2016, atezolizumab joined our party without an acute need for yet another remarkably similar agent with a very similar indication. How might atezolizumab distinguish itself as a compelling treatment option? I think the OAK trial did a pretty good job of that. It enrolled 1,200 patients with non-small cell lung cancer who received 1 or 2 prior lines of chemotherapy. It didn't require any level of PD-L1 expression, and it randomly assigned them to receive atezolizumab dosed at 1,200 milligrams or docetaxel. Atezolizumab was associated with a significantly superior overall survival and longer median overall survival as well by more than 4 months. The overall survival benefit was identical across non-small cell lung cancer histologies, and there was no crossover design allowed in the trial. Safety also favored atezolizumab by wide measures. We also had the Poplar trial that helped atezolizumab get FDA approval as well. It included patients who received more than one line of previous treatment. 35% of those patients in those trials were third-line treatment patients. So keeping that in mind, objective response rates was about 19%. Across the board, about 20% of lung cancer patients will respond to immunotherapy. So I feel like when we're selecting an agent, this is one where cost and administration could play a role. Now, this is a moving target. There are about 250 open and enrolling trials on clinicaltrials.gov for nivolumab, atezolizumab, and pembrolizumab in lung cancer patients. And there are 2 more investigational agents making their way through the pipeline. There's a lot of trials exploring immunotherapy in the first, the second, the salvage line setting. There's also trials that are exploring immunotherapy in combination with CTLA-4 inhibitors or immunotherapy in combination with chemotherapy. So as more data emerges, I anticipate we might get a preferred agent. Lastly, immunotherapy has made substantial waves in the first-line setting. 2 agents have been evaluated in the first-line setting. We have nivolumab and pembrolizumab, and they both paint very different pictures. In the phase 3 CheckMate 026 trial, 541 patients who are at least 1% PD-L1 positive were randomly assigned to treatment with either nivolumab or standard first-line platinum doublet chemotherapy. Patients with EGFR and ALK mutations were excluded. In patients with more than 5% PD-L1 expression, progression-free survival was better with chemotherapy than with nivolumab. Now, contrast, we have the Keynote 024 trial that compared pembrolizumab to investigators' choice of platinum doublet chemotherapy. And it enrolled 305 patients who had PD-L1 expression of more than 50%. And again, patients with EGFR and ALK mutations were excluded. Progression-free survival was 10.3 months for the pembrolizumab, compared to 6 months for the chemotherapy. And overall survival at 6 months was 80% in pembrolizumab. So why was the trial with pembrolizumab so positive and the trial with nivolumab so negative? There are several explanations that have been proposed, but the major issue appears to be patient selection. It's been suggested that nivolumab did not improve progression-free survival over chemotherapy because they included this really broad range of patients with low PD-L1 expression of just 1% or greater. In addition, there was very high rates of crossover in the nivolumab trial. About 60% of patients who failed chemotherapy crossed over to receive immunotherapy, compared to the Keynote trial that had much lower rates of crossover. So that could have muddled the statistics a little bit. All right, let's put the picture together. I was looking for this wonderful closing slide, and I walked by our shared whiteboard, and I saw this image, and to me, it's perfect. So we spoke a lot about targeted therapy and immunotherapy and how it compares to chemotherapy. But in the most simplistic of terms, if you are staring at a healthy patient without significant comorbidities, what would be the appropriate treatment option? A newly diagnosed non-small cell lung cancer patient should be tested for PD-L1 expression. They should have next-generation sequencing to evaluate EGFR and ALK mutations, as well as other mutations we didn't have time to talk about, like ROS1 and BRAF and MET. If they are positive for these mutations, you are going to start them on a TKI if possible, or chemotherapy. Apparently that's an option now. If they are positive for PD-L1 expression, more than 50%, pembrolizumab is probably your agent of choice. And if they are negative for all of the above, chemotherapy is where you're going to begin. So thank you so much for taking the time to listen today. It was a sincere pleasure to discuss these exciting agents that are available to lung cancer patients now. So at this time, I would love to open the floor up for any questions you may have. Thank you. Oh, no.
While we wait for people who may have questions, I do happen to have one. Now that we have pembrolizumab approved as a first-line agent and we still have these other checkpoint inhibitors, is there any role when patients progress, to switch to another checkpoint or use them further down with therapy?
That's a good question, and I don't think there's enough data to elucidate whether or not patients should follow up with a checkpoint inhibitor. I know in melanoma that is the recommendation, but I don't think there's enough data to suss it out. Most providers would probably switch to chemotherapy at that point. Yes.
Hi, thank you. That was a great presentation. I had a quick question regarding the different PD-L1 assays. I know that currently there's 4 different ones. The 3 immunotherapies that you mentioned, also one for durvalumab. And I was wondering what challenges y'all have had with the different testing, or do you do all 4 PD-L1 assays in-house? And if you require send-outs, and what's the process for that?
Yes, send-outs for sure. Apparently the machines to test PD-L1 expression are very expensive, about $1 million. So we test them all out. It does take a long time to get your PD-L1 testing back, which is unfortunate for patients who have these aggressive tumors and you want to start treatment immediately with them. But that is the only option we have right now for our center.
I have one question, if you don't mind,
Yeah.
just in terms of cost effectiveness, in terms of these agents. I know they're quite expensive, all of them. Which ones would you recommend in terms of moving forward in a cost-effective manner in terms of the immunotherapy agents?
Sure. Our internal data has favored atezolizumab. It seems to be the most cost-effective agent out of all 3. It also has the best administration at every 3 weeks. Nivolumab seems to be the most expensive. But I would also advise you to look at the NCCN value-based guidelines. They do have really good blocks to help you guide which therapy you're going to start. But it should be institution and provider decision driven as well.
Further questions? I have yet another question. Nivolumab actually has associated with it a nursing questionnaire that when the drug was approved, it showed up on the websites, et cetera, and the drug companies were sending that out. Pembrolizumab does not, and atezolizumab does not seem to have that. Are you using any sort of nursing monitoring to determine side effects that are associated, the immune-mediated side effects that are associated with these agents?
We currently are not, but that is definitely a good resource for patients. We do give them patient wallet cards, which display the most common side effects, and if we have patients from rural areas, it's good to go to an emergency room with a wallet card to also say, hey, I'm on nivolumab, or hey, I'm on pembrolizumab, just so that helps those providers assess how to properly treat these patients. So we have used the wallet cards for the patients, but we have not had nursing checklists. So that is something to look into.
Okay, if there are no further questions, we'll close the session and get you guys to lunch early.
Thank you,
Thank you very
guys.
much.